Please welcome our next speaker with a big round of applause, Dr. Krishna Lalakota.
Good afternoon, everyone. I just wanted to make it swift to last no more than 15 minutes. So just going to run through, but if you have any questions, I'm happy to take the questions at the end. Before we start doing any procedure, obviously good preparation is entirely necessary. Just make sure you have the patient who's got correct indication. And before you take up, obviously you need to have the patient on optimized medical therapy. And make sure patient is euvolemic as much as possible. And then anticoagulation, which is sometimes missed until the patient comes up to the table. So just make sure you go through everything before you start your procedure. And then explain the procedure very clearly to the patient and the success rate as well. And then patient should have reasonable expectations. Typically, more often than not, we do the procedure from the left side, but occasionally we'll have to do from the right side, which is slightly different, but generally about 99% of the procedures are done from the left side. So for this procedure, typically, as you all know, you need 3 vascular accesses and then adequately hydrated patient just to get good access, and then make sure if patient has got renal failure, nephrotoxic drugs and everything are managed very well. And then this is a very important thing because in most of the hospitals I've seen in India, we tend to put a temporary pacemaker lead in place. But you can do the other way around. If you already have 3 accesses, you can go with the RV lead and then go with the CS cannulation. So I'm not going to go through the general pacemaker implantation steps. But the things to remember and to have most importantly is the anesthetist to hand, because CRT can last anywhere between 1 hour to 4 hours depending on how difficult the branches are. So you need to have a good anesthetist friend standby, surgical standby in occasional circumstances, Foley's catheter. So once you start, these things are very important. Once you become expert, obviously, some of the things you can skip through. And then have some guide wires to hand, because they are not supplied by the company which will give you the device. So a couple of good guide wires which are very familiar with. And then occasionally balloons are necessary to do venoplasty in rare circumstances. And then if you are working in an EP lab, obviously steerable EP catheter is going to be helpful to cannulate the coronary sinus. But what I generally do is I am not EP as such. I'm interventionist and heart failure specialist. So we take a levo shot first. After putting a temporary wire here in India, still most of the place, and then you can see exactly what is the reasonable expectation, what sort of coronary sinus you have. So if you look here in this picture towards the end, so you can see there is only one specific branch, so that will be your target, and that seems to be actually a reasonable target. And then what I usually do is to take and that is where you want to aim at. And then the most important steps in implant procedure are first you need to cannulate the sinus, and then take a venogram picture of the coronary sinus, and then select appropriate leads based on the branch sizes. And then we place the leads, remove the implant tools, which is again very important step, because that is where everything can fall back, and then you will have to go back and start the procedure right from the beginning. And then check whether the lead moved, and then check the electrical and programming parameters, and then you finish your procedure. So there are a lot of delivery systems. So I've got some pictures of Medtronic delivery device catheters here. And then if you look on this one, they've got different shapes. Different shapes for different size of the right atrium. So the general, in 90% of the cases, the MB2 or the regular routine one, if you ask the guys, the company guys, they will give you the MB2. That tends to sit in about 70% of the cases. And then for a higher ones, then extended hook. And then if you are using a EP catheter, then you need a straight one. And then if you're doing from the right side, you have MBR, which is for the right side. And then the kit contains all these things. And then before you start, obviously, you need to connect this connector valve to the guide sheath. And then this is one picture which shows the guide sheath being used along with the EP catheter. But the main procedure, obviously, you enter and then start torquing the anti-clockwise, and then it's right behind the tricuspid valve. You will enter the coronary sinus. And then occasionally, if you enter the tricuspid valve into the RV, just pull back and start giving anti-clockwise torque. Generally, you will see it. The procedure which I generally tend to use is using a catheter along with the sheath. And what I tend to do is just this. Use the Amplatz catheter. This will negotiate the Thebesian valve, which is usually on top of the, just around the CS. So just check whether you're in there and then send any wire. Generally, normal J wire will do, but occasionally, if it is difficult to push it through, then you can use the Terumo wire. And then once you got the wire, and then push the Amplatz into the CS, and then guide the guiding catheter on top of the Amplatz catheter, and then you'll enter the coronary sinus. And then once you are in there, you have a picture somewhat like this. And then you make sure you check you are in the sinus. And then the next step is to take a venogram catheter or a balloon catheter. And then the important thing here is to just avoid complication is if the sinus, the main coronary sinus is actually not very thick, you need to reduce the amount of the air, otherwise that's where your procedure stops, because any higher pressure in the CS, it can actually dissect, and then obviously you may end up postponing or cancelling the procedure. And then once you have a picture, you will have different types of CS anatomy, as most of you know. It's quite variable. And then I've got some pictures here just to go through. And this is what I have done. Sorry, with this mouse doesn't move very freely. So once you are in there, inflate the balloon and inject and then actively deflate the balloon. Then you will have all the branches. As you can see here very clearly, there is only one major branch in this one, but that seems to have several sub-branches, so this is going to be adequate. The way not to do the CS angiogram is just put your balloon in front of a branch. So this I just done just to demonstrate what can happen. If a balloon is in front of a branch or a bifurcation, then you may miss whatever one available vein, and you may not be able to see anything higher or below that. So this is important to just make sure you put in between the branches. So this you can check while you did the first step. And then obviously you have different size of leads available, 4 French, 5 French, and 6 French. Depending on the lead size, the branch size, then you can choose whatever is the most appropriate lead. And then all these leads are over the wire leads. That means once you identify the branch, just like angioplasty, you send your guide wire into any of these branches of your choice, but generally anterolateral branch would be the most appropriate. Middle cardiac vein generally tends to give you poor parameters. And then on top of the guide wire, and you have something called subselects. Occasionally it may be very difficult to enter the side branches, then you can use one of these subselect catheters which will go through your usual guide, and then enter the branch, just point it into the mouth, and then you can enter your guide wire into that one. And 4 French leads usually go through these subselect lead delivery catheters. And this is the picture how the lead allows the guide wire, and also the lead shape actually becomes a little bit straighter. And this is the lead without putting any wire through. Although it looks to have two curves, as soon as you put the lead over the guide wire, it tends to straighten up and you can negotiate most of the branches without any difficulties. And this is a special lead used for wider branches. If you have only one branch, and that is actually much wider, most of the leads tend to fall off. As soon as you take your guide wire back, the lead tends to fall back into the main branch or just comes from the target area. Then you can use this particular lead, which is called StarFix. And just by pulling the white bit behind here, you can deploy lobes all around. It just looks like a star, and it's got 3 different stars. And then just by pushing and pulling, you can change the position as well. But once you have done that, and then once you suture, that remains static. And as I said, not only just the guide wire, even by putting a stillet, you can actually make the lead straighter. And then once you find the appropriate branch, just place the lead and then start withdrawing the guide wire, and then only check, because the guide wire tip can give you false parameters. And then going through the large vein and going through the smaller vein, how the lead can change its shape is just a little diagram to show that the original lead, and going through the smaller one, larger one, and also the initial bend can be used to negotiate into the side branches, and then you deliver your guide wire through that particular branch. And then occasionally the bends can be more than 90 degrees. Then you have a different subselect catheter to help you. Here is the picture which I've done. So you just send the guide wire through there, and then make sure if you remember the first branch, I've selected the lower side branch of the sub branch, and through which I've sent the lead. But unfortunately, when I pulled the guide wire back in about 2 minutes, this lead came back. So what I had to do was to go through the next branch, and then that time it was actually much more stable. So just by selecting slightly different smaller sub branch, you can actually make it much more stable. And the most important thing is you will have to have both the curves of the lead in the side branch, otherwise your lead is never going to be stable enough. And then you check once you got your lead in place and your guide wire back into the lead.
Dr. Krishna, another 2 minutes for you.
Okay, that's fine. So then withdraw the implantation stools. This is the slitter for slittable catheter. Slitting procedure, I've just drawn a little graphic here. You just fix your right hand after engaging the blade into the guide, and then you just do one movement with your left hand and swing your body around. So that's the way, and that all should be in one movement. Then otherwise, you're very likely to displace the lead. And that's the final lead position. I just put all the pictures together just to make sure we go through. So take a lever face and take the engage into the coronary sinus, and then check once you engage the guide. And then make sure your wire is in place into that particular branch, and then put the lead on top. There you go, pull the guide wire back, and that's the end of the procedure. Thank you.